you're still in the hospital. Mr. Hafiz.
Good evening, sir.
Good evening. How are you?
Yeah, I'm fine, sir. How are you, sir?
Fine, thank you.
I have co-hosted, sir, Dr. Ranjan, sir, and Dr. Hafiz, sir.
Dr. Narsimpai also.
Narsimpai. Done, sir.
I've called up sir. He's joining in 2 minutes. Yes, sir.
Hello, sir. How are you?
Hi, good evening, Dr. Ranjan. Nice to see you.
Yes, sir. Good to see you. How is Switzerland, sir?
Oh, it's quite bright and sunny today.
Oh, nice, nice.
Dr. Narsimpai was asking you.
Oh, is he already in? Okay.
Yes, he's already in. Yes.
Hello, namaskara, Dr. Pai.
There he is, yeah.
Yeah.
Hi, Ranjan.
Hello. I think you start class start ಆದ್ಮೇಲೆ ಒಂದು ಪ್ಲಾಸ್ಟಿಕ್ ಮಾಡಬಹುದಾ ಅಂತ ನೀವು ಮಧ್ಯದಲ್ಲಿ
ಇಲ್ಲ FFR ಮಾಡಬಹುದು ಇವತ್ತು. You're ready?
Yeah, I'm ready.
We'll wait for another 5 minutes. Then
5 minutes. If you want, should I share this one and keep?
Yeah, you can check your slides, Ranjan.
Yes. Yeah. Is it visible, sir?
Oh, it's coming up. Not yet. Yeah. Yes.
And the presentation mode also, no? Yeah.
Yeah, this is presentation mode. Moving on.
Yes.
Yeah, that's fine. That's good. So we'll join after 5 minutes at exactly 4:30.
Yes, sir. 4:30 for you there, sir.
Yeah, sorry.
It's good. Yes.
8 o'clock.
We'll join, sir, in 2 minutes.
Yes.
Thank you, sir. Bye.
Thank you. Dr. Afsar?
Yes, sir.
I didn't get any reply from Kumar.
Yes, sir.
Did you speak to any one of them?
Sudhakar, sir, I have spoken, sir. He said he will get back in a day, but I think I will call him up again, sir.
So today you will confirm it. Tomorrow let me know whether I will arrange something else.
Yes, sir. Yes, sir.
Yeah. So tomorrow you let him know without fail.
Yeah, tomorrow morning I'll just get back to you, sir.
Yeah.
Sure, sir.
Patil has not joined.
Shall we begin, Ranjan?
Another 2 minutes, Dr. Pai.
Yeah, okay.
We'll keep it. Yeah, correct. Once more, no? It's okay. I did it already. We'll start at 8, no, sir? Yeah.
Yeah, 1 minute
Okay.
left.
1 minute,
Yeah.
yes.
Recording in progress.
Hello.
Hello. Yeah.
Yeah, Nagraj.
Good evening, Dr. Nagaraj. Welcome. We'll just start. Good evening, ladies and gentlemen. Welcome to our Monday musings. And I take great pleasure today to invite Dr. Narasimhan Pai to introduce the speaker and the topic. Dr. Narasimhan Pai, over to you.
Yes, thank you, sir. Am I audible?
Yes, you are.
I think our speaker of the day does not require any introduction. Dr. Ranjan has been a very dynamic young interventional cardiologist, very good friend of. He has worked for many years in KH Manipal and then moved on to Bangalore. And he has very many special interests, especially LA appendage closure and FFR and iFR. So I guess Ranjan is speaking on one of his favorite topics, that is the resting indices in evaluation of coronary physiology. Gone are the days today when we used to stent based on anatomy and based on the angiography. Today, if you have to be full-fledged, if you need to do scientific work, you need to know insights into the coronary physiology. And I'm sure that in the talk over the next 35-40 minutes, Ranjan will touch upon all these aspects. I do not want to intervene him right now. Probably we will get back at the end of his presentation. Over to you, Dr. Ranjan.
Yeah, thank you, Dr. Pai, for kind introduction. Thank you, Dr. Iyengar, for managing the whole scenario and also joining in during your vacation. And I welcome all of you to this session. So it will be a very short presentation. I'm going to keep it short and we'll keep some time for discussion. So today we are going to discuss about resting indices. So as we realize that we know Dr. Pai already told us that, without just an angiographic angioplasty is probably outdated now, and with more and more data coming in favor of FFR or IFR guided angioplasty, it's very important to do it in intermediate lesion. Probably the future will be that we may have to do it in every lesion except ACS, acute coronary. Whenever there is a stable heart disease, we may have to do this. So guidelines over the period have increased, the recommendations have gone up from, class 2A to class 1 most of the time, and level of evidence also, because there are many trials now. From B, it has shifted down to A. So even in multi-vessel, even when we are sending to, most people think that if you do FFR, IFR, the number of angioplasty would come down. It may not be so at all, in the sense that in a multi-vessel where we think it is, all these blocks are significant, hence it is multi-vessel. Some of them need not be multi-vessel. So even for CABG and decision about angioplasty, FFR or IFR, some sort of a physiological index is needed. Now, FFR has been there for a long time, but to be honest, there are 2-3 things which happens when we do FFR. One, there is obviously the procedure gets delayed or prolonged. Second, the wires are right now, they're expensive. You're actually trying to prevent a coronary stent, which costs 30,000 now, whereas the procedure costs 60-65,000 a year, with discomfort and with the non-uniform response. And then if you're not careful, you can get whatever number you want. So that is not the way to do FFR. When you're doing FFR, you have to have an open mind, any physiological. And with that open mind and go by the data, also make sure you're doing it properly. The technique is extremely important. I think one of the earlier classes, we did have a talk about FFR. So today we are resting on resting indices. Now, when we talk about resting indices, we know hyperemic indices is FFR. The non-hyperemic indices are many actually. The simplest one of them is actually PD by PA, which is whole cycle. There is also RFR, which is resting flow, RFR, which is resting full cycle ratio, which is, each company has patent here. You have DFR, only diastolic subcycle. You have DFR, which is with Boston Scientific. You have IFR with the, which is with Volcano, brought over by Philips, and you also have other indices, which is DPR, that is diastolic pressure ratio. Now, the good part of most of these is the cutoff is just single. It's 0.89. So almost all resting indices have one cutoff, it is 0.89. And FFR, we know in current era, the cutoff is 0.80. Initially, when it started, it was 0.75, then there was a borderline zone. So it was 0.89. It's interestingly just the PDPA is also a good indicator, but the cutoff for that is 0.91. So just remember 0.80 and 0.89. Now, what do we do? How do we do? It's important to do, important to look into that. We know PA is iota, PD is distal. So when you're looking at RFR, which is resting full cycle ratio, you're going to look at the full cycle, both in systole and diastole, whereas most others are actually in diastole. So IFR has obviously more data because it was the first one to come, but there is also data for other parameters. So let me start with IFR, because this is how the science began and science developed. And let's see, and the data for IFR also is more. So IFR is instantaneous wave-free ratio. So in a wave-free period, that means there is no, in the wave-free period, that is this period in a cardiac cycle. So this, this is the dicrotic notch, and this is the pure diastole. In this period, wave-free period, the ratio between the distal, which is the coronary, and proximal, which is iota. That is what we are seeing. So in FFR, we see the whole thing, but during adenosine, here we are seeing here. Now, why this period was chosen? Because it is believed that at this period, the resistance is naturally constant and it does not get varied much. See, that's all you want to know, because most of these depends on the microvasculature. And we believe that FFR is when we paralyze the microvasculature. and measure the proximal versus distal ratio. Here, if there is a zone in cardiac cycle where microvasculature resistance is constant, that means the determinant of the pressure, distal pressure, is actually the degree of stenosis. So the ratio between the proximal and distal there makes sense. So there were studies which showed that throughout, normally cardiac cycle and the blood flow is phasic, but this particular period, the so-called wave period is a portion of diastole where the resistance is independent of heart rate, blood pressure, CAD, and location of the coronary artery. The resistance. Since the resistance is independent of all these parameters, a simple pressure gradient would actually depict the level of the degree of stenosis, and it makes sense. So that is what is iFR. How is it done? Technique very, very identical to FFR. It's the same wire which is now put across. So we go through the leg, we go through the hand, like angioplasty. The software is different, and there are algorithms which are different, and it was commercialized initially by Volcano, which was later bought over by Philips. The reason why we are happy with those resting indices is adenosine is unreliable. There is always a controversy about whether it should be intracoronary or whether we should do intravenous. May be problematic in asthmatic patient. Low blood pressure, again, it goes up and down. And you should be very, very careful when you use adenosine. Even a drop of blood entering into the adenosine chamber could deactivate adenosine, and it may not work at all. And also the problem what you get is when you give adenosine, sometimes the patient goes into heart block. There is so much hemodynamic instability, everybody rushing here and there. And what FFR can we get? So they produced the hypothesis where resistance was measured initially during resting period, and it was similar to mean resting during hyperemia. So in this period, whatever resistance they measured was actually equal to maximal vasodilated, paralyzed. The resistance was comparable. So it was believed that this period could be used in resting state and should not be used as adenosine. The hypothesis 2 was, if you use the resting wave period, that period, and if you do a PD by PF, it would be the way you measure PD by would be similar to what you get it in FFR. So hyperemic, this was the initial study, and their animal study where they actually did hyperemic mean resistance and compare with the resistant wave resistant, and they were comparable. So that's where the concept of wave period came. So this is the period where we could do. And we know that, the general rule for FFR, it is 0.80. If it is less than or equal to 0.80, you treat it even equal, okay? And if it is more, you differ. Whereas here, 0.89 is the cutoff. Initially, obviously, there was a gray zone, which was 0.86 to 0.93. But anything less, anything more was actually was a differ. Now, what happens if you take both of them together in a particular patient? You use both, because most of these studies actually used FFR as gold standard and compared with iFR. So there was a reasonable correlation. I wouldn't call it exact, a linear correlation. There was a reasonable correlation with iFR as 0.9, means 0.89 or less is actually significant. So 0.9, and FFR as 0.8. The R square, in a linear equation, we look at R square. R square of 0.66 is considered was reasonable, and the formula was developed. We'll also discuss what happens if there is if they don't match or they don't follow, one positive, one negative, what happens? We'll spend some time in discussing, but this is what we do. Now, one big problem when it comes to resting indices, people claim that FFR has data, whereas iFR does not have enough data. But it's probably not true. You look at these trials now. If you see FAME and FAME2 and DIFFER, these are the 3 trials on which we base our iFR. The whole gamut of FFR is based on these 3. But the number of patients there is 888,509. Whereas iFR, Sweetheart and Defined Flare trials actually have much bigger sample size. So it's not that iFR does not have data. In my opinion, they have almost equal data compared to FFR. Now, let's go to these 3 trials, because this is what we are supposed to discuss, because what they did in Define Clear and what they did in Sweetheart. Now, both were randomized trial with huge number of patients, 2,500, 2,037. In Define Clear, they took FFR. There was FFR guided PCI and there was iFR guided PCI. Cutoffs which we know. More than 0.8 you differ, less than 0.8 you perform. Same thing with iFR also. More than 0.89 you differ and less than 0.89 you perform. So, and then they had 30-day, 1 to 2 years and 5-year follow-up published in New England Journal. And the same issue of New England Journal. We all know that New England Journal tries to change the guidelines. So they tend to put 2-3 good trials in one issue, and the practice practically changes after that, even more than what the guidelines say. The Sweetheart again had 1:1, iFR guided revascularization same, and FFR guided revascularization same cutoff, and this had 12-month follow-up here. Now, what did it show? So iFR guided, when the iFR guided angioplasty was used, the number of stents used were actually less and patient discomfort was less. So number of stents were less in iFR guided versus FFR guided, and which was true in both the trial. Total adverse event as expected is less with iFR compared to FFR, and that is what we see in both these trials, the symptom. So that is the first part. So iFR actually leads to less stent utilization, and most of the time, in syntax and other trials, we know that using more stent actually leads to more adverse event. And treatment allocation, this is what happens in when you use iFR and FFR, it's almost comparable, and the maze, when you use the maze is also comparable. Numerically, it could go here and there, but if you see the p-value, whether you use iFR or FFR, was same. There was no increase in event rate in deferred patient and significantly less revascularization with iFR. That means iFR actually makes you use less stents, but not at the cost of adverse outcome. There is no adverse outcome which happens. If you look at the primary maze, both FFR and iFR actually matches and the p-value is significant, and that is seen in both the trial. See, in both the trial, the p-value is, it's non-inferior to each other. When one iFR is up and one FFR is up, it doesn't matter. It's just a numerical difference and there is no difference. Now we know that best cutoff of FFR is 0.80. When we study, multiple trials give multiple cutoff, but better to stick to 0.89 as a cutoff. A consistent cutoff for iFR is actually 0.89. So this is how we do. What are the other advantages? What happens? So we could take 0.89 as a cutoff for FFR. This was the gray zone, and then there is a iFR zone which comes in the either of the section. So, but like for example here, if you look at this coronary lesion, which is like almost the routine lesions which we have in practice, a circ here has multiple blocks. So which of these is physiologically significant? Visually, I feel D is significant, A is significant, maybe B also visually. But what does the hemodynamically which is significant? It is actually this which was the most significant, B, and others were not significant. So in a multi-lesion, when you have multiple lesion, FFR is a nightmare. If you have 2 lesions, tandem lesions, it's a nightmare. And how to treat, what to treat, the values keep going up and down, and it becomes extremely difficult to do any analysis with FFR. You can't keep the wire in between, in FFR. You have to go distal to all the wires. Then probably even a math genius will not be able to actually decipher the numerical value. What we are supposed to do is use IV, see the step up, and then try to do this. Whereas in iFR, when we do, see, for example, there are 2 lesions here. The distal iFR is 0.83, 0.86, and at this point is 0.92. So what we can do in iFR is, you could. It's much easier. You position the wire to the point where you would like to intervene. Look at all the drops. You could do the pullback. You could do things without much problem. So typically, the algorithm which was initially used was 0.89 PCI. This is anything between, more than 0.93 is optimal medical care. 0.93 to 93, that is where probably better to do FFR. And if FFR is positive, do angioplasty. And if FFR is negative, optimal medical. So this works quite good. First, using IFR as the first modality works better because you are not using adenosine. Only a small number of people you do this. But this is for non-invasive, where you know that ischemia is definitely there. If you don't know the ischemia, then probably use 0.86 as the cutoff, and anything more than that, this becomes borderline, and do the FFR. That is what you do. Now, the importance of this is co-registration. Co-registration works wonderfully well because it just tells you which area to treat, which area to not to treat. There's no need of hyperemic drug. But the point of caution when you're measuring FFR is you can't measure as soon as you give nitrates, dye, or adenosine, nothing. IFR is all about patience. You pass the wire, you're not touching the patient for 30 seconds, you're standing back, you're not even checking, and then measure. You give anything. You give even dye, which is a vasodilator, or nitrates, or adenosine, whatever, the IFR value will come down, but that's not the true value. You cannot give anything, just give and wait. That is what you need to do. So good part of co-registration, if you have a co-registration in your lab, it shows like this. As you pull back, this is, the dots are, it gives dots. Each yellow dot indicates 0.01 IFR, 0.01, So like, for example, here, if you stand from here to here, the gain of IFR, because this particular lesion, the drop of IFR is by so many points. This could be 10 or 11. That means here, if it is 1, here it will become 0.89. And here it will become 0.86. So each dot indicates 0.01, and you can do virtual stent. So if there is one point with lots of dots, that is the sudden steep increase, and that's a focal stenosis. If you have something like that, it is diffuse stenosis. But you could also do virtual stenting. You can actually guess, if you stand from here to here, this is the IFR which you gain. If you stand from here to here, this is the IFR which you gain. So IFR advantages: no adenosine, less procedural time, wonderful for sequential lesion. FFR data is good, prognostic significance is present, but it's a nightmare if there are multiple lesions and you want to understand. Now 20% of the lesions have discordance. Now what do? That means one of them is positive, other is negative. That depends on your practice. You could start with FFR first, you could start with IFR first. What we do now is we start with the IFR first and stick most of the decisions on IFR, because we know that IFR is this. Very rarely use FFR. But what do you do for discordant? Whenever there is discordant, the general rule is, it's all risk versus benefit. If it is discordant and if it is a focal lesion, stent. If it is discordant and if it is diffuse, long stents, don't stent. That works very good for clinical scenario if you have discordant lesion. But wherever it is concordant, it is very easy and the data is quite good. Now, what about other hyperemic index? There are many of them we did discuss. How do they fare as like IFR? Do they fare good or do they fare bad? So this is the study where all different methods were controlled, and this, this is FFR versus IFR diffuse. This we can skip. What happened? Discordance we already discussed. So if it is a discordant focal lesion stent, discordant diffuse, don't stent. So there are many studies which talk about discordance of IFR and FFR, and as you know, the question is definitely unanswered, but better to go clinical at this point. Now, what about new resting indices? We have diastolic pressure ratio, which is DPR. That is all the diastolic pressure ratio. We have this is the algorithm which is there for diastolic pressure ratio. We also have, now these are the different indices. So a study which compared the 6 resting indices versus IFR. Here, something interesting came up. Almost all of them are very, very concordant. That means whether you use RFR, IFR, DFR, or whatever you want to use, they are extremely concordant. The discordance here is not much at all. They are almost close to unity. See here, they are like the values just match on each other. So whichever you want to use, the advantage of this is it's almost unity. Where I told when it is FFR, IFR, there was a lot of discordance because of the technique itself and the physiology itself. Because here we are looking at resting indices which have little different understanding. It's almost unity here. So that means you could use any of the resting indices which is available in the lab, and they all should be following the value of IFR, because the data for IFR is higher, other don't have. Just look at the area under the curve. They are positive, negative predictive. They just match each other. So whichever you take, it's almost the color of rainbow here, but they are just exactly the same. Whichever you want, you could use. They would all have a good correlation with each other and little bad correlation with FFR. That means their area under curve for FFR is much lesser, but between each other, they are wonderful and they work well. So RFR is now available because Abbott markets it, and it's a full cycle ratio, and we know it's independent of ECG. It just looks at the waveform and it is okay. So there are trials like Validate RFR which have shown us that it works, but I think the key slide is that one slide that whichever resting index you take, it is fine. So again, just to say, RFR versus IFR, the validity is extremely high. IFR versus FFR is 81, RFR versus FFR is also 81. So they are almost always divergent. Wherever IFR diverges, RFR also diverges. It could use. Diastolic hyperemia ratio is a ratio between PD and PA here. Again, pooled analysis shows almost same. Not too much difference here. These are two different lesions, and the numbers always match when you take any resting indices. So with that, I think I will, the same thing, equalization should be done in the proper way. Please go back to that lecture where we discussed the FFR, steps to be taken at equalization. Do not put this. Look at the waveform. Don't just look at the number. Be very careful. Be very patient. Just keep this. When you are doing a pullback, you cannot use any dye when you are using a resting. Any of the resting indices. You just have to do. If you have co-registration, it works well. And the data for post-stenting is different. It's believed that after a beautiful angioplasty, after the person who is doing the angioplasty has beautiful result, up to 25% patients are still ischemic, and most of that ischemia is focal. That means there is one area within the stent which is actually not post-dilated enough. So it's very important, if you are doing it pre, do post, show that the the ischemia is treated, then the long-term outcome would be much better. So thank you all of you for your patient hearing, and I'll be happy to take happy to have discussion here.
Thank you, Dr. Ranjan, for your short but crisp presentation, I would say. And I think you have touched on most of the points, both flow-related and independent indices. If any of our participants have any questions, they can post in the chat box or message to observe so that Ranjan can answer back.
There seem to be no questions. Any comments from any faculty members or even anybody who wants to comment? Ranjan, basically these are based on the pressure based on the pressure change, right?
Yes, sir. Yes.
So I think if we want to achieve more accuracy in identifying ischemia, we should have both pressure and flow.
Yes.
But that would increase it will not be easy. So the resting indices will come exactly, I think, the balance both the accuracy and the ease of measuring it.
Correct. Correct.
Yeah.
I totally agree, sir. Ideally, it should be flow. So that means you might need a Doppler. Doppler based measurement to actually do. But fortunately, these indices they're here to stay. There's data, and in future, probably all stable coronary artery disease, even the insurance might insist on FFR based, like in US now, they have to show ischemia either with a non-invasive test or do a FFR and iFR and show that there is something before they stent. So it may not just be for intermediate lesion, in the sense not for 50 to 70, it could be for 50 to 90.
And these values of, say, for example, 0.89 cutoff or iFR has migrated from, it started with what, 0.83, then 0.86, then 0.89.
Yes.
So I think that is in the first study, I think, was 0.83 or something.
Yes, first study was 0.83, sir. Then what they thought was 0.86 to 0.93
was a gray
as a border gray zone, and you do FFR. Now it's almost universally 0.89. Yeah.
Yes, and that applies to all the diastolic, non-hyperemic indices.
Yes, yes. All resting indices have, one cutoff, all resting indices, and the beauty with they correlate with each other is actually fantastic. That is something which is, because honestly the logic of RFR is different from logic of IFR. IFR probably is the most thought about, where they thought that particular period has resistance which is standard, independent of so many parameters. But RFR cannot follow that, because RFR is a full cycle. But even that, the cutoff exactly matches of this. Yeah.
Yes, that's right.
Dr. Ranjan. Good evening.
Yes. Dr. Desai, yes.
Yeah. In fact, when I was even starting my career about this, measuring the pressure gradient across the lesion was considered as an important development.
Yes.
Subsequently, there were some considerations like drawbacks or caveats. Would you like to draw attention to the drawbacks of measuring the distal gradient and how it can be fallacious in a given patient?
Yes, I think this is a very important question, Dr. Desai, because there are lots of assumption which is done. We didn't go to that, but you are absolutely right. For example, it is believed, we actually, if you look at the formula of FFR, there is LVEDP is part of it, but we assume that LVEDP is normal, or we take it off. So there are many conditions where this doesn't work. I think I should have mentioned some of them. For example, aortic stenosis. In aortic stenosis, actually the FFR we'll assume it to be positive, right? False positive, but it will be false negative, and IFR will become false positive in aortic stenosis. Because you look at microvasculature at aortic stenosis, it is never fully dilated or never not dilated. It's in between. So IFR will come positive because it's not really resting. It will come positive, whereas FFR will come negative in case of aortic stenosis. Same thing is true for HOCM and hypertrophic cardiomyopathy. It's also true for hypertension. Now, any condition where LVDP is high, there will be, again, the FFR will be false negative, because now the distal pressure goes up. So it's assumed these are not for all cases. We have to be careful. FFR again predicts viability to some extent. To some extent, it is not a surrogate marker for viability, but yes, a less viable, less supplying myocardium will come negative. There are fallacious. There's also a recent study, very recent, which talks about FFR negative. That means FFR is negative, but if you do a OCT and you show a thin clap athyroma, and if you stent those lesions, so-called borderline to severe, the event comes down. Because we keep seeing this, now that we've been using for 2-3 years. I've had patients where last year FFR was negative and this year he has come with NSTMI. So you always wonder which are those FFR negative which you could leave. So using a OCT as a where you're also looking at the plaque. If you see a thin cap and this one, if you intervene those patients, the event comes down. A certain number of FFR negative come back. That's what we should understand.
Another
some
point that
questions.
I wanted you to highlight
Yeah.
could be, how often do you measure LVEDP in the lab?
Yes. Not much at all, sir. So basically, these are done. These tests should be done where you assume LV function is reasonably normal, and you are not suspecting systolic or diastolic dysfunction, because we don't do it and we don't put it in the formula at all. So you should be, both systolic and diastolic dysfunction should be ruled out. Any other area, you should use your previous judgment. For example, in severe AS, when you're doing TAVI or anything, coronary lesions need not be addressed unless they are in, left main or proximal LAD. Any other coronary lesion, whatever it looks, can actually be left, and using any of this physiological marker does not help us much.
Grade 3 collaterals to the segment or the coronary, where you want to measure the fractional ratio. Are there any comments from you on that?
Yeah, I think whenever there are collaterals, which may be because of the graft or because of the natural collateral, the FFR, the distal FFR, is the summation of both. It is a summation of all those things. RFR is not ideal. It has to be FFR, because RFR believes in a pure resting. You can't have baseline vasodilatation for any reason. So it is FFR. So in those things, FFR is ideal, and the distal FFR is a combination of both. So sometimes there is a donor artery, which makes it tough. Now the donor territory increases. For example, LAD collateralizing a CTO RCA, if you do FFR to LAD, it might come positive, but once you open up the RCA, do the angioplasty, the FFR of LAD now can be negative because the territory has decreased. But if you have not done any intervention, then a distal FFR is a summation of both native as well as the collateral flow.
Thank
Nasim
you.
Pai, sorry. Dr. Nagaraj, any more comments?
No, thank you so much.
Dr.
Lovely
Nasim Pai,
presentation, very useful.
Thank you. Dr. Nasim Pai, there are some questions in the chat box. Can I read it for you, or?
Yeah, I think one more question and then I think we'll go. Ranjan, which are the cases where you will never do an FFR?
Never do, huh? Yeah. If
No,
there
no,
is a,
I mean, I'm not telling in tight lesions, in where it is otherwise indicated, but you would be reluctant to do an FFR or a functional assessment.
Yeah. I think the
I hope
thing
you
about,
got my question.
yes, I understood. So in a ACS scenario, the STMI, the rule is because the microcirculation is abnormal. So 5 days from ACS, 5 days, that's the cutoff. Now you don't do FFR. But non-culprit artery, again, you can do a FFR. Dr. Iyengar gave a beautiful talk sometime in this, I think, very forum, where he told what happens if you do IFR and what happens if you use FFR in non-culprit artery. Even there you err, You in one, you end up using more stents, other you end up using less stent compared to others. So I think any ACS, unless you are pushed for it, don't do FFR, IFR, because we still don't understand. And culprit artery, never, not for first 5 days. Non-culprit, if you're forced, you do. I think it's better to stage and do this. See, one important message is a borderline lesion is a borderline lesion. Nothing is going to happen in a borderline lesion if you don't have to jump and do. Medical management is a very, very good option for a borderline lesion. So we can always call them back when we think hemodynamic is fine and evaluate them. Yeah.
Some questions in the chat box. Shall I read it, Dr. Pai?
Yes, sir. Yes.
Yeah. One is, sir, in borderline lesions, how does anatomical evaluation with intracoronary imaging compare with physiological evaluation by FFR and IFR? I think you should have slide.
Yeah, I think it's a very, very important question, very interesting and important question. I think to answer it simply, it has to be physiology which decides whether you stent or you don't stent. It has to be physiology. Don't go by anatomy, but physiology. Once you decide to stent, use anatomy. Then you use imaging and stent it very well, So size, stent length, dilatation, all that you use anatomy. So as much as possible, use, whenever doubt, use physiological parameters to do. Maybe in ACS where you're not sure, you could use anatomical parameters, or to differ. Again, anatomical parameters are useful to differ. Like left main 6, you don't have to put stent, differ. To, anatomical lesion, imaging should not be used to decide on stenting. They are more useful to differ stenting. left main lesion, what to do? Yes, traditionally the data for left main is with FFR, not with IFR and RFR, but it's the principle holds good even in those scenarios. So it should be okay to use them, but traditionally it has been FFR, yes, but it's okay. So I think there's
a
a
request from Dr. Anuradha. Please tell the final message, like take-home message for the purpose of latecomers.
Yes, I think, thank you, Dr. Anuradha. The talk was, to do FFR, it takes more time than my talk. But we did end it so fast. So I think the key message is use physiology wherever possible. Whenever you are in doubt, if the lesion is anywhere, if it's troubling you, make sure you use physiological measurement. In physiology, I think today's era, after this talk, and even otherwise, I'm more convinced, use resting indices. But be very careful. Don't use too many, manipulation. Just keep the wire, stand out for 30 seconds. Be very comfortable. Use the resting indices. If it is above 0.89, I most of the time leave it and don't do too many maneuvers there. If it is less than 0.89, we treat. Very, very rarely nowadays, I've been using FFR because of time, adenosine, and do the pullback. Make sure once you finish, pull back, bring it to iota in the sense the guiding catheter. Make sure it is 1. You may have to keep normalizing or equalizing. It's not about getting a number. It's about being convinced that this case needs angioplasty or no. Once you decide, you could use anatomical lesions. So one question about whether the left main lesion, will we put the wire in LAD or L6? You have to put it in both LAD and L6, and then only assess. Any one of them significant actually means left main is significant. So you have to put wire in both.
It's good. And I think Dr. Anuradha had one more question. FFR for extra coronary vessels.
Yes, there the data is actually limited, not too much. But renal, I think it makes sense in the sense, renal stenting is never stood out of this one, and evidence is coming down. That also indicates that we are not probably stenting the lesions which needs to be stented. So there needs to be bigger studies to do that. Using adenosine in a renal artery may not work, So all you're doing is a resting FFR or post-NTG FFR. We're not sure whether adenosine will dilate the renal vessel. So it will only be this.
And Dr. Ranjan, do you recommend the routine post-PCI, this IFR?
Yes, I would recommend, sir. I would actually recommend, because you'll be surprised in what you find. And there is data definitely to show that we need to do. Cutoff here are different, not 0.89. It will be 0.94 and 0.95. Both for FFR, IFR. So the cutoffs are different here. If your wire is friendly, IFR wires are not very friendly, but RFR wires are quite friendly. You could do the intervention in RFR. So in such lesions, actually, I would recommend that you do the angioplasty on the wire, measure the final FFR, RFR. If it is low, just do the pullback, see whether it is focal. If it is focal, all you need is one post dilatation within the stent. So most of the time, the abnormality is focal within the stent. So it's something which we can, it's not about deciding to, RFR is positive, you have to stent, but you have to stent it right, after that. We need to make sure it is fine. If you are using imaging for all your cases, probably you don't need it. But if you're not using, I think better to continue the procedure and document.
Thank you. Any other questions or Dr. Narsim Pai, concluding remarks? Dr. Narsim? Dr. Pai?
Yeah, sorry, sir.
Could you
very much here, Dr. Ranjan is answering the questions. I think, hello?
Yes, Dr. Pai.
Yeah, I think physiological assessment of coronary lesion is here to stay. Yeah. Probably in ACS, what Ranjan mentioned, and maybe in patients with LV dysfunction or obstructive valve lesions, the role may be limited. But definitely in determining whether we need to stent a non-culprit lesion in a multivessel PCI, FFR or IFR is the gold standard. And though we do not have much data whether IFR guided PCI, FFR guided PCI is superior to non-imaging guided PCI, because at the end of 1 year the event rate looks fairly same. Though we do not have trials on a large scale supporting the utility of these modalities, I think for a physiologist, for a coronary interventionist, these are tools which make intervention more meaningful. That's what probably I would like to put it. And definitely I think Ranjan in all his justice has tried to explain and enlighten our postgraduates this evening. I thank Ranjan and I thank Dr. Iyengar sir for giving me an opportunity today to chair and be with you. Okay, thank you.
Thank you, Dr. Nasimpai. Thank you, Dr. Ranjan, for that excellent presentation with all your experience. And I thank all the delegates and thank our Manipal team, hafeesh, and for having given us this platform. Thank you. Thank you, officer.
Thank you, sir.
Bye-bye.
Recording.